Dear ladies and gentlemen, welcome to our today's ZEF public lecture. We are having Dr. Yasobant. He will be delivering his lecture on the topic of multi-sectoral collaborations for routine health services during COVID-19 pandemics in Ahmedabad, India. Preliminary findings from COVID Intersect project. We will be having the session for the next couple of minutes, followed by a question and answer session. But before we go in for a presentation, let me give you a brief introduction about Dr. Sandal Yasobant. Dr. Yasobant is working as a technical officer at the Indian Institute of Public Health in Gandhinagar, India. He's a postdoctoral fellow at the Institute of Hygiene and Public Health, University Hospital of Bonn. He's an associate researcher at the Center for Development Research, as well as an adjunct faculty at the Data Mega Institute of Medical Sciences in India. He also holds editorial affiliations with Springer Nature, Frontiers, PLOS in Thailand and Francis. Originally from Odisha, Yasobant has completed his health education and public health training at Utkal University, Sri Ramchandra University in India, and at the University of Bonn in Germany. He has completed the doctoral programs, One Health in Urban Transformation at ZEF, and obtained a public health doctoral degree from the medical faculty of the University of Bonn in 2020. Yasobant's research incorporates health policy and system research, One Health in disease prevention, and environment and occupational health. Yasobant has conducted extensive research in Southeast Asia and is currently engaged in research activities in India and Ghana. He has published more than 50 peer-reviewed international journal articles and book chapters, as well as edited one volume of the book. Without further delay, I would like to invite Dr. Yasobant to take over the floor and tell us more about his topic. Thank you very much. The floor is yours, please.
Yeah. Thank you very much, Faisal, and very good afternoon, and thanks for this long introduction. I'm pleased to be here with this Jeff again, because it's almost now 2 years I left Jeff, and it's my honor to be here. So this is a project after I left Jeff was funded by the TFG, and it was a Prologue started with the same from my own doctoral study, that where we investigated the intersectoral collaboration, how that works in the perspective of One Health. But this project was combinedly by the Uniclinicum, IHPH and IIPHG, where I work currently. So the topic goes like this: the intersectoral collaboration and the health services during COVID-19. So as the title suggests, that we want to look into how the health services is affected or the disrupted during COVID-19 pandemics, and how the health sector was strengthened with the intersectoral collaboration or the assistance from other non-health sectors to provide this kind of services in Ahmedabad, India. So before entering into the topic, I thought to just give a prologue about the COVID-19 pandemic, how Ahmedabad managed this one. And of course, there was like a lot of debate, either it is a good or bad, but I'll not go into that. But there are certain initiatives which aligns with this concept of intersectoral collaboration, that the health sector of the health department of Ahmedabad Municipal Corporation was strengthened from different settings, from the different sectors. So some of them, I'll start with the famous one is the 4T strategy, which says the tracing, testing, tracking, and the treatment, which is the I think in the COVID-19, the philosophy was how far or how good you can trace the new cases and test them and track them and then treat them. So Ahmedabad Municipal Corporation developed some kind of antigen testing domes across the city, and it was the numbers was in the 3 digits, and there was like deployed of health professionals, and even from the medical professionals, medical schools, the peoples from the residents and the medical colleges, they were engaged with all these activities. And it was a good initiatives between the public health department and the medical education, which mostly works independently, but they came into a collaboration and developed this kind of strategies. The second one, good initiative was the household survey, the screening, which was, although there were a lot of household surveys was keep on going, but intensively to find out the new cases and to treat them or isolate them, the screening was developed with the help of not only from the community health workers, which is a I can say the huge volume of community health workers were present in India, but also some of the non-health workers were engaged into these activities, and they were trained in a very fraction of, I think, the weeks, and the screening activities was amplified with the support from other sectors. Another initiative was the 114, the fever helpline, where any citizen could call them and say that any kind of symptoms, and that was a kind of like provisional diagnosis to rule out either it is a COVID symptom or not, or to guide them where to go for the testing and so on. And in this particular activities, the students from different colleges were volunteered to do to this kind of activities, which shows the multi-sectoral collaborations between the education department and the health department. Similarly, sorry, another initiative was something called Dhanvantri Van, which is the colloquial language name, but it indicates it's a complete package of ambulance which consists of different professionals, including some essential medicines and the assisted for which is required for the community. So it keeps on moving from one place to another place and provide the services also. Another was about the developing the quarantine centers, because there was a lot of issues on international and even the national travel restrictions. So the government is supposed to provide each and every support to the people who are suspected to have the COVID to establish the quarantine center. So let's say the hostels, the schools, all those were converted into the quarantine centers, and which was like with only collaboration with different sectors and the settings that we can say. After all, when this vaccination started, there was like a lot of effort to targeted population of vaccination, let's say the elderly. I'm sure there was a lot of strategies developed in the low and middle income countries, but one of them is to go with the vaccine box to the community, to the household level, to provide the vaccination. So the doorstep vaccination was one of the initiative, and even the below picture shows the like test drive kind of like test vaccination, the drive vaccination. So drive-in vaccination was also possible with the Department of Road and Transport, where you don't show the vaccination certificate, you're supposed to go for the COVID vaccination. So these are some of initiatives to give the prologue how the non-health sectors amplified or strengthened the health sector activities in the pandemic situation like COVID-19. But the question comes here is that, of course, we know this COVID-19, and it's a fact, and even the WHO also agrees that during this kind of pandemic, the disruption of essential health services is almost happened in all countries. It's not respect to the lower middle, but also in case of high income countries. And how we recover, that's a learning for all of us, because this is one of the biggest pandemic that ever seen. So, but the potential problem with that disrupting any kind of routine services. So when I mean the routine services is something, let's say the maternal child healthcare services, the pregnancy and delivery care. So it is one of the routine care or the essential services that need to be maintained even in any situation, or let's say immunization. The vaccinations need to be maintained in any kind of situation of health system responsiveness. So because that has a loss of life that can potentially be avoided if we do that. But one thing, the major gap is that the coordination and the harmonizing efforts from non-health sectors to the health sectors is remained a challenge. So the things that has been emphasized here is that the intersectoral collaboration is all nothing but if I want to define, is that it's the support from the non-health sectors to protect the health of the population. And it's mostly about the context of interlinkages between different departments to go for any kind of health service delivery. So the overall message is that the maternal and child reproductive health services should be supported and maintained during any kind of pandemic. So that's how we say that irrespective of type of severity of any kind of pandemics, we have to maintain at least some essential services, and among that one is the maternal child health care, including immunization. And this depends how the health system structure looks like or what kind of capacity of that particular health system has. But the problem is that how to maintain the services, the type of collaboration that require for maintaining or undisrupting these services is quite unclear. One of the evidence that we generated from specifically from my own doctoral studies that the research to intersectoral collaboration for One Health approach to look into how the health system structure looks like during a pandemic and as to be more specific, during an outbreak and during a non-outbreak situation. So we investigated 2 points of time, the similar stakeholders, how they interacted in between them, or the collaboration looks like during an outbreak. We took the example of 2017 avian influenza. It's called bird flu outbreak, which is the Ahmedabad is one of the city that was affected. And compared with the trend of the situation in 2019, which is exactly the time point where the data collection was being conducted. And we look to that, these two difference or the picture indicates that the network density definitely is higher because it's the outbreak situation. And it's reduced when the such kind of situation went off, and the collaboration, the degree, everything was reduced during non-outbreak situations. So that makes us to understand that how this collaboration minimize the disruption of essential health services during this pandemic disease outbreak. So that was the main objective that we want to answer it out. To follow that, we specify with the evaluating the degree of intersectoral collaborations and how that's between different levels of health systems and even to the non-health sectors. And we want to assess how the COVID-19 pandemic has disrupted the provision of essential routine health services, both from the public and private setting. So that was the two specific objectives that we looked into that. Coming to the settings, that is, I was talking more about Ahmedabad is a city of having 8 million population in the western part of the India. I think it's the seventh most populous city of India, but it makes a context to be more specific why we choose again to investigate the COVID-19 to be done in the Ahmedabad, because this city, the darkest circle is the Ahmedabad, which is one of the most high reported cases in the state of Gujarat. And the second one was from the south side of the Gujarat. But the maximum the reported cases and the fatality rate was also higher in case of Ahmedabad. And that makes the case more stronger why we again investigated the COVID-19 collaboration pattern in Ahmedabad. So administratively, the 6 zones and the 16.6% about of total cases in Gujarat is existing in Ahmedabad. This is the trend, how the Ahmedabad looks like in reporting the cases in 2020, the first wave, the July to October, the first quarter, we considered that is the first wave of the investigation. And the second wave, where definitely the number of reported cases were high and the fatality were high, is the 2021 April to June. That was the second wave of the COVID-19. So that was the 2 point of time investigations. And we investigated how the collaboration was there between the health and non-health sectors for pertaining to essential health services. Our investigation went off 3 different levels of health systems, because it's more look like about how the health system structure of India looks like, because there were certain people, the community health workers, they exist at the community settings, those who are like more essentially do or deliver these routine services at the doorstep. So our 1 point of investigations were there. And of course, the pregnant women or the ladies, the mothers, those who have delivered during the COVID-19 pandemic, we want to undertake their perception, their challenges, or what went well or not well with them. So we covered those 2 different types of populations in the community level. And here in the clinical settings, especially the public and private, the physicians or the medical officers, those who are providing those services, and how they get strengthened with from non-health sectors. That was the main point of evaluation at the clinical settings. In the private providers also, we included some of non-health sectors clinicians, like, for example, veterinarians. So how the services was there, and they collaborated or not collaborated with the other sectors. And during in the administrative interviews, we almost covered both the health and non-health sectors, those who were engaged in COVID-19 management and health service delivery management in the city of Ahmedabad. So with this, we started with, as it is a mixed methods, our data collection went with starting from some of qualitative interviews to surveys. So at the type of involvement with stakeholders, the roles and responsibilities in pandemic management, in service delivery, that was the kind of investigation that we looked for. In the network survey, we looked for the plan of actions, prioritizing activities, how they decided which activities need to be implemented in respect to pandemic management or not. So those kind of the things, involvement in service delivery disruption, and of course the quantifying, and some parts of collaboration strategies like task shiftings, what was the motivation during pandemics, all those were covered during this survey. And of course the experiences of the mothers during pregnancy, type of maternal child health services, immunization services, and their challenges were captured. So coming to some of the key findings, that about, it's a golden number, 2 mothers were covered with a clear-cut stratification of both COVID positive and COVID negative mothers, because we wanted to look into how the COVID-19 mothers are also either faced any kind of challenges or not. So that took us to have this equal case control numbers of equal divided numbers of the mothers. Some were also the mothers, the interesting cases were documented in the form of in-depth interviews. So the problems or the key findings, although the surveys keep on going on, some of the key findings. So this is at least the guidelines indicates that antenatal care visits, the ANC stands for, that means before the delivery, one mother should have this at least the 3 number of visits to the primary health centers. And this National Family Healthcare Service indicates 82.4%, where in COVID it was strangely increased to 95.9, which is a positive findings, we can stretch it out. And similarly, the institutional delivery, that means a delivery conducted by a medical officer or the nurses, increased from 97 to 99.5. So which indicates that pandemic is always not bad. That means in certain health services, it increased some indicators, like means although there was fear to COVID-19, the people went for the institutional delivery. So there was, even in Indian context, there is still about 3 to 4% of home delivery cases are there, but it increased to 99.5%, the institutional delivery, and also the institutional ANC visits were increased. But in case of certain indicators like the immunization, the tetanus dose, either they received the 2 doses or not. This is a service delivery which is decreased drastically. Received any follow-up visits after delivery was also decreased. So in certain sense, some pandemic made us to deliver some things in a panic way to increase in some indicators, but in some indicators it's also reduced out. Another problem was that about 25% of pregnant women changed the plan to the actual place of delivery. That means they were forced to go to some other facilities which are not COVID designated facilities, and so on happened. And the majority was the COVID-19, the fear. Here are some qualitative findings. The majority says that I have to travel for the COVID designated, the public health facility, is because the strategy that was developed in Ahmedabad setting was that not all the primary health centers supposed to handle the delivery cases. They shifted all the cases to certain tertiary cares, which was the designated spaces. So the traveling was another issue. Some mothers, even without COVID positive status, they were shifted or the plan to deliver in some other places because of certain infections in the healthcare professionals. There was also public to private shiftings of delivery places, which was quite not common. most of people from the nearest facility visited to households. That means that they indicate that the health workers, the community health workers, still visiting to the households, irrespective of pandemic situation. And it's a quite it's a tricky situation, because some of health services need to be delivered at the household levels, but it won't signify or correlate to the findings. While we switch to the findings from the community health workers, it was of course we asked like different ways that what are the challenges that you didn't able to deliver the services that you're supposed to. The of course reason from their side was that increase of workload because they were engaged in pandemic management. And of course, there were some social reasons, like the family worried about the safety, and there were activities more than months for the COVID-19. They were deployed for other things. The fear was the most common reasons, and the travel, as I said, there was a lockdown and so on. So that was one of the issue in the system side. But same times, the households were also the fear to accept the visit of any health workers, even they know them. The community fear, the reluctant to meet to the service providers. These were kind of the barriers that made the community health workers not to deliver that kind of routine services that what they're supposed to be. Similar way, if you see that how the first wave to the second wave, the service disruption happened, mostly, although the first wave was not severe, most of services were stopped during the first wave, that means May to July 2020, but it was recovered during the second wave, given said that the number of cases were high, the fatality rate were high. The only reason is that there must be some learning and how to maintain this disruption of services irrespective of pandemics. And those learnings were important to maintain the health system resilience. If you see, almost all the services were reduced from the disruption, were reduced from first wave to second wave, either it is antenatal care or a routine immunization, any of the services. So that was one of the important findings that we learned from the pandemic management, how to maintain these services, even in addition to maintaining the pandemics, managing the pandemics. When we asked the clinical providers, there was certain challenges at their level also, because they were supposed to convert some of the facilities. So let's say the one private gynecologist was indicating that the emergency care what she was having, it was converted to the COVID care facility. So she's supposed to not to conduct any kind of delivery irrespective of mother status, irrespective of mother is COVID or positive or negative. So that means they have to shift to some public health facilities. At the private sectors, there were some indication that they paid more, channelized the resources, the AMC for the smooth functioning of emergency care units. So they were supposed to convert those kind of facilities. So that means there was a good negotiation between the government and to the private settings to provide this kind of services. One of the issue that we identified during the kind of asking the clinical services that was provided to other non-health sectors. So for example, veterinarians. So some of the issue was that it was not emphasized as much as the human services. That means the pet owners were stopped during the access to any veterinary clinics. And some of the veterinary doctors were simply stopped working during this whole pandemic time because of the different issues, either the supply chain and the workload also. But this kind of initiatives were also reflected in the non-health sector. So let's say the health sector, when they were like more into the pandemic management, like oxygen procurement or remdesivir, the drugs like managements, but the non-health sectors really emphasized the service delivery of the health sectors. And how there was one example that the education department, the grassroots level survey and data collection, including data on travel, was maintained by the education department, which was a part of COVID management, and some of the health sector staffs were relieved because of not doing this kind of activities, and they were engaged in routine services. Similarly, the fire safety department, the real estate department, or the waste management, animal husbandry department. So all these sectors were directly or indirectly supporting to the health sectors for providing the different kind of services. So that shows a clear example how this collaboration pattern was maintained during the pandemic to provide this kind of routine services. What we envisage during the further investigation of the routine data collection, as well as to complete this project by maybe in a quarter of time, is that to how extent the essential health services disrupted in during COVID-19 was one of the point that we want to answer it out in Ahmedabad setting. We want to challenge, document these challenges during the lockdown, specifically for the maternal child healthcare services, and to be more specific, the delivery care and the immunizations. And we want to document the gap analysis to strengthen the essential health services, and that will definitely help the future pandemics. And of course, how the intersectoral collaboration took a major role maintaining this whole routine health services. So with this, I must acknowledge to the Ahmedabad Municipal Corporation and to the exhausting the field team, they were keep on working since now. I should stop it here. Any questions, suggestions will be appreciated to answer. Thank you very much.